Hello, everyone, and welcome to today's webinar from the Peterson Health Technology Institute, What Works and What's Worth It, Assessing Virtual Musculoskeletal Solutions. My name is Jared Augenstein, and I'm a Managing Director with Manat Health. Manat provided consulting, research, and operational support to PHTI in developing this report. I'll be moderating the Q&A at the end of the call. For now, I'm going to pass it to Caroline Pearson, Executive Director at PHTI.
Thanks so much, Jared, and thanks everybody for joining us. I am delighted to be here with you today. As you all know, PHTI is an independent, self-funded nonprofit that provides rigorous and evidence-based assessments of digital health technologies. We launched PHTI in 2023 because we fundamentally believed that technology, if thoughtfully adopted, has the power to improve efficiency and effectiveness in our healthcare system. However, despite broad adoption of digital health tools, we heard from the market that there were many challenges with assessing and evaluating those tools. So we launched PHTI to try to bring some clarity to the space. As many of you know, our first report came out in March, focused on digital diabetes solutions. And today, I'm very excited to share the results of our second assessment, focused on virtual musculoskeletal solutions, which was released last week. One important thing that you'll see today is that we use the exact same methods and same approach between both assessments to very different results, and I'm excited to tell you more about that. During the webinar, I'm going to present findings and then take Q&A. I encourage you to submit Q&A questions in the Q&A box at the bottom of your screen. On the next slide, we'll share a little bit more about how we approach our work. Fundamentally, we want to drive more market adoption of high-value digital health solutions. And we seek to do that by helping to clarify evidence standards so that people who are both assessing and purchasing digital health technologies and those who are generating evidence about them understand what those standards are and what compelling evidence looks like. We then conduct our evaluations on sub-segments of the digital health market to really identify which solutions work and have the potential to save money. Our hope is that with clarity about independent information, we can drive more purchaser adoption, as well as patient and provider acceptance of these solutions, really hoping to speed the time to adoption for great technology from innovation to wide market acceptance. Next slide. Since the release of our first report, we've been actively engaged with stakeholders across the industry, and I wanted to share a little bit of the feedback that we've been receiving before we get into our results. I was excited to join the chief medical officers of the health plans at AHIP earlier this week and hear a lot about how they have been actively reviewing and using these reports within their own organizations. Many of them tell us, your findings are really validating what we have already experienced in our use of these tools and in our own membership, but it is very helpful internally to understand how our experience fits within the broader context of the evidence to enable future decision-making, whether that be to adopt new solutions or to rethink solutions that are already in place. We hear that they are actively using this information to guide their contracting decisions, both now and into the future. We've also been in close touch with many investors who increasingly are saying that they are looking at their diligence teams and handing them our report and saying, this is what good diligence looks like. And that is a delight to me because we would love to have clinical evidence and economic impact be at the center of diligence, in addition to all of the other important factors that investors are looking at as they're making funding decisions. To the extent that we have clarity on what purchasers are looking for, those are going to be the key to growth for these companies, and investors understand the importance of this work in that context. We've also had active dialogue with many digital health companies, including those that were included in the diabetes report, those described in this report, and many other companies who are thinking about what PHTI means for their future. And we have appreciated the vibrant engagement and feedback both in shaping the report on our this report and upcoming reports, as well as telling us what did and didn't work for them in past reports. And we're thinking hard about all of those pieces of feedback as we continue our work. And then finally, we've been getting a really warm reception from policymakers. PHTI does not have an active policy agenda, but we understand that federal regulators and policymakers can benefit from information about evidence about digital health solutions and technology integration into care. And so we've been in regular touch with leaders at the health agencies as well as on the Hill to share the findings of our work. Next slide. I want to tell you a little bit about our approach to our assessment. And if we go to the next slide, you'll see that we really designed PHTI to answer the core questions that are driving digital health purchasing. We regularly work with our Purchaser Advisory Council, which is comprised of employers, health plans, and providers to understand what information they need and they're looking for as they're making digital health purchasing decisions. And it really comes down to sort of three core questions on the right-hand side of this slide. First, do these solutions work? And importantly, for whom? We too often are deploying technologies broadly across big swaths of the population. And increasingly, we hear that purchasers want to understand where are the patient populations, the subgroups, or the time in a patient's care journey when technology can have the greatest impact, so that they can increasingly think about how to put solutions into the hands of folks where it matters and at the time that it matters the most to them. The second question is, are these solutions better than the status quo? These technologies are being integrated or layered on top of existing care plans and existing provider structures. And as we're looking at evidence, it's important not only to look at how virtual solutions are impacting patient outcomes, but how those outcomes compare to more traditional care models, including usual care. I'll talk more about some of the comparators when we get into the details of the MSK report. But for each report, we're thinking hard about what are the right comparators for us to be looking at in the evidence base. And then third, for solutions that are delivering strong clinical value, purchasers want to understand whether they have the potential to lower costs. Obviously, purchasers are making decisions based on many factors, including outcomes, access, and convenience. But they are also making decisions in budget-constrained environments, and they want to understand the budget impact of those decisions as they integrate new solutions. Next slide. When we set out to do this work, we worked closely with ICER to build off of their decades of experience assessing prescription drugs, but also to pivot and create a custom assessment framework that was bespoke for digital health technologies. We understood that these technologies are different than drugs, they are changing and innovating at a more rapid pace, and they needed a unique assessment framework that was really suited to this market. That includes different standards about the types of evidence that will be considered, far beyond just looking at RCTs, but including a wide range of real-world evidence and observational study designs. Within that evidence base, we look at two core areas for our assessments. First and foremost is clinical impact. Is the product clinically effective and is it safe? In addition to how the user experience in terms of accessibility, ease of use, and adherence to the technology. We also look specifically at health equity in terms of how the solution works for people of different backgrounds and experiences. We then look at economic impact, assessing the budget impact at a population level on a 1 to 3 year time frame, which is really the time frame in which those purchasers are making active decisions. Throughout our work, we are actively engaged with stakeholders to make sure that we have informed decisions from folks that are regularly thinking through these questions. And so I want to talk through a few of our different stakeholder models. On the left-hand side, we have both an advisory board filled with leaders in the field who have worked in many different digital health companies, purchasers, investors, et cetera. And they give us advice at a high strategic level about where PHTI should be going and how we should be thinking about evolving our work. They do not, however, have any participation directly in our assessments or in the selection of our assessment areas. Many of those folks have active conflicts, and we want the best of the thinking from people that are actively in the space, but we want to make sure that we take conflicts seriously. Similarly, the Purchaser Advisory Council that I mentioned is a critical group for giving us input to understand what are purchasers focused on in the digital health space, what's the information they need, and what are the areas of technology that we should be looking at as we're thinking about selecting our next topics. But they too do not have any direct participation in the assessments, nor do they get access to the information before its public release, which goes out to everybody free on our website. We do have 4 core groups that provide direct assessment and participation during our report process. First are the assessment partners, Jared being one of them, as well as many other health economists and health technology experts that help our PHTI team execute their work with high quality and fidelity. Second, we recruit a group of clinical advisors for each of our reports that represent the core clinical areas that are going to be touching any of these solutions and any of these patient populations. And those folks really help us understand things like what usual care looks like in all of its heterogeneity out in the world, as well as which clinical outcomes we should be focused on as we do our comprehensive reviews. We conduct direct research with patients through both interviews and focus groups to understand their care journey and how technology fits into it. And we work directly with the digital health companies that are part of the assessments to give them the opportunity to submit additional business information as well as clinical data that may not yet be available publicly. So let's get into the results on MSK. So first and foremost, why did we choose to focus on MSK disorders and virtual MSK care? Well, we know that musculoskeletal disorders affect 1 in 3 people in the United States and are a huge burden on people's lives, as well as their ability to work and carry out all of the activities of daily living. We also know that physical therapy has the potential to improve outcomes and reduce healthcare spending if people get into physical therapy early in their care journey. If they don't, we know that many people undergo unnecessary and avoidable treatment, including surgeries, advanced imaging, use of pain medication, including opioids, as well as injections and other intensive care, many of which can be avoided if people get PT early. Unfortunately, we also know that many folks that would benefit from PT simply do not start it or are unwilling to pursue it because they may not find it convenient, accessible, they may have transportation challenges or scheduling challenges, and we also know that many of them worry about the cost of PT under their existing insurance benefits. Interestingly, when we spoke to patients, one of the things we heard most was both from patients living in rural areas, as well as older adults, many of whom don't drive themselves. They said getting to PT during business hours or far from my home is going to be really challenging. And so we understood that these technology solutions have come out to try to create more convenient and accessible access to PT for people who may benefit. Now, it's important that I mention here that not all patients are going to be appropriate for virtual PT. For instance, patients with high frailty or fall risk are not going to be well positioned to conduct PT at home on their own. And in our report, we really looked at folks with general MSK disorders. We weren't looking specifically at evidence on people doing physical therapy for pre or post-operative conditions. And we weren't looking at folks with neurodegenerative diseases like Parkinson's. On the next slide, though, you will see that for many people suffering from things like low back pain or neck pain, there are a variety of virtual physical therapy solutions that have come to market to try to create broadened access and convenience for these services. And while each of these services varied somewhat in their design, they have a few core components. Generally, they begin with an enrollment and intake discussion, typically with a physical therapist, often through a live interaction to determine whether it's appropriate for the person to be getting virtual PT and to build that care plan. Then many of the exercises and active physical therapy activities actually can be done individually without the one-to-one oversight of a physical therapist. So most of these solutions have folks overseeing and designing care plans, but then patients are actually conducting the exercises on their own independently in their home and at the time that they want to conduct their exercises. They all have used technology to give patients feedback about the exercise. So in fact, you put your tablet up in front of you, it will give you feedback about range of motion, it will keep track of time and reps, And then all of that converts into data, which can then be overseen and monitored by the health coach or the physical therapist on the back end. Some of these solutions have additional wraparound services as well, things like mental health engagement and the ability to have coaching outside of your exercises. So on this slide, you can see the range of physical therapy solutions that we looked at, or virtual MSK solutions that we looked at, and we grouped them into 3 core buckets. On the left-hand side, you see the app-based exercise therapy solutions. These are solutions that generally have more limited engagement from physical therapists and rely more on coaches or on automated oversight of data and exercises. The middle category is physical therapist guided solutions. These solutions all use physical therapists throughout the care journey, from intake to exercise plan design and to data oversight. And then on the right-hand side is something a bit different, which is the RTM augmented PT solutions, with Limber being the largest example of a vendor in this space. And those solutions are being sold directly to providers and then generally being reimbursed through the remote therapeutic monitoring codes. And they're being used to augment in-person PT. So folks are going to in-person PT, their physical therapist is recommending that they complete exercises between their visits, and they're using these digital solutions to guide those exercises between visits. Across all of these solutions, we've got some similarities. They are all using technology, whether it be sensors or computer vision, to guide the exercise regimens. They're generally being sold to health plans, or in the case of the RTM solutions, to providers. And in order to set a scale for maturity and company size, we've cut it off at companies that have more than $10 million in investment funding, again, really as a proxy for company maturity in terms of evidence generation and the ability to contract at scale. Next slide. As we approach our work, we conducted a systematic literature review in which we screened more than 2,000 pieces of evidence. And as a reminder, we are generally looking at published evidence in the white and gray literature, or evidence that is submitted to us by companies, in this case from the past decade. We're not conducting any original data analysis, nor are we receiving information directly from health plans or employers to guide our findings. Now, in this report, we looked at 15 outcome measures, similar in scale to what we did on the diabetes. But as we look across the evidence and gather and collate all that evidence across those 15 outcome measures, we need to think about which are going to be the primary clinical outcomes that we're going to look at, and then what are the additional outcomes that matter the most. In the case of musculoskeletal conditions, we really focused on solutions that can demonstrate clinically meaningful improvement in pain and function. Now, pain and function are complicated. There are 20 different measurement scales that were included in the evidence base that we found here, each of which have different numerical ratings and different thresholds for what clinically meaningful improvements are. And so what we did in this case is actually convert each of those scales to a more simple comparator to how did we see sort of inferior, comparable, or superior performance relative to between the control arm and the intervention arm. And I'll talk a little bit more about that. Anyone who wants the detailed numerical results can find them in our very lengthy appendix, which is posted on our website. Pain and function are really sort of the hallmark of progress and healing in musculoskeletal care, but there are many other outcomes that are important, and you see those here at the bottom of the slide. I'll highlight a few. Mental health, we know that patients that are suffering from pain or functional limitations also tend to struggle with mental health conditions, and so a number of the solutions have worked to both gather evidence and provide mental health support as part of their solutions. We also know things like medication use are very important given the opioid epidemic in the country. The importance of getting folks healed without the use of opioid medications can be critically important for both public health reasons and individual sustainability. So as we get into the results, I'll show you on the next slide. we really looked at these primary clinical outcomes with, in this case, two comparator groups. First, we looked at how each of the virtual solutions performs relative to usual care. And in this case, usual care really means the wide variety of care, ranging from rest and ice and doing nothing, to seeing your doctor and getting medical care or getting injections. But usual care in this case generally does not include regular in-person physical therapy. And when we look at the evidence base about virtual PT relative to this usual care that doesn't include in-person PT, we see that all of the solutions across all of the categories deliver better improvements in pain and function relative to usual care. And that's very consistent with what we see in the in-person physical therapy literature. Rest and ice, while beneficial, is not as good as exercise and physical therapy. So that tells us that these solutions have the potential to expand access and improve outcomes for patients who are otherwise not interested or would not go to in-person PT. So next we wanted to understand, well, how could these, and if we can go back one, how could these solutions compare to in-person PT? We know that in-person PT is the gold standard and is what is recommended for many people with musculoskeletal conditions. And what we find is that the physical therapist guided solutions, that middle category, generally demonstrated improvements in pain and function that were comparable with in-person PT, which means that for some patients, these solutions may be a substitute for in-person PT if patients are interested. We also looked at specifically the RTM augmented solutions, and those are a bit different because they are in fact not substituting for in-person PT, but they are augmenting in-person PT. And there we actually saw superior improvements in pain and function for people that conducted RTM-driven exercises between their in-person therapy visits. Next slide. As we look at secondary outcomes, we see a variety of other benefits that were quite promising. So the secondary outcomes included significant improvements in mental health, in workplace productivity, and reduced use of opioid medications for users of the virtual solution relative to usual care. We also wanted to look at user experience, and generally the solutions all performed well. We saw relatively similar rates of retention in terms of people completing their PT between in-person and virtual. And we found that people with virtual solutions actually tended to complete slightly more sessions per week than folks with in-person PT. So we see similar sort of engagement among those users. Perhaps most importantly for these solutions, when we look at health equity, we saw strong results for racially and ethnically diverse users, as well as older users. And as I mentioned, these are some of the groups that potentially benefit the most from having access to virtual solutions as an alternative to in-person PT. And so we were really pleased to see that performance looked strong for both of those groups. So in summary, this gives you a sense of what the clinical findings looked like. And you'll see that we found good results for both the physical therapist guided solutions and the RTM augmented PT solutions, each of which performed comparably or better to in-person PT and create a clinical alternative for patients for whom it's appropriate. What's also interesting in this evidence is that it really underscores the importance of physical therapists, licensed physical therapists, being part of the process. Each of the solutions in these bottom two categories have taken the APTA pledge and used licensed physical therapists throughout their care journey. And we see that in the results, whereas the app-based exercise therapy, while superior to usual care, has not proven the same improvements in function as we see in in-person PT. Next slide. So I'm going to pause before I get into the economic findings, and I would like to invite Justin Moore from the APTA onto the call. And I'll give you the context that, we do our evidence reviews. I told you sort of who's involved, but as we reach the end and we begin to formulate our point of view, it's important that we always try to reach out to the specialty societies and the disease groups for whom these findings are going to matter the most. And I personally was very excited to reach out to APTA because for those of you who read the letter at the front of the report, you know that I have had a lot of PT experience in the last year. And I really understand the value that physical therapists play in both the emotional and the physical recovery from serious MSK conditions. And so I was excited to reach out to Justin and to share the findings with him and to hear their reactions. And so we welcome him here today to share a little bit more about their view on this evidence. Justin.
Thank you, Caroline, and thanks to all of you for joining this briefing by the Peterson Health Technology Institute. As Caroline said, I'm Justin Moore, Chief Executive Officer of the American Physical Therapy Association. APTA is the membership association for individual licensed physical therapists and physical therapist assistants in the United States. We are delighted to join the Peterson Health Technology Institute in this briefing, and we commend them for their work to evaluate digital health technologies as they become a growing part of our healthcare landscape. PHTI's leadership, investment, and expertise has positioned them to be the leading source for objective assessments on digital health solutions. And these assessments are essential to guide decision makers on how these technologies are going to fit into the ever-changing healthcare landscape. APTA was particularly interested in PHTI's assessments of virtual musculoskeletal solutions that was released last week, because most of these solutions leverage physical therapists as their primary strategy in addressing MSK conditions, as physical therapists has consistently, as Caroline discussed, demonstrated high value to patients, payers, and purchasers in addressing these musculoskeletal conditions and their associated costs. APTA was thrilled to see that one of the key highlights from the report is that research continues to show that early access to physical therapy benefits all: the patient, the payers, the purchasers of healthcare services. PHTI's assessment of virtual health musculoskeletal solutions builds on this foundations, and its implications show that guided solutions by physical therapists show the greatest potential. As digital healthcare solutions for providing physical therapy began the rapid entrance into the market, APTA was originally concerned about the adoption of these solutions without standards or objective assessments. PHTI has worked to narrow that gap, and we are committed with them to closing that even further. Our initial concerns were centered on the misuse of physical therapy or a lack of qualified providers to guide this care through these solutions. APTA was committed to maintaining that standard in the profession and protecting the integrity of the term physical therapy and the title physical therapist as outlined in state law. And so we've always protected that regardless of whether this care is provided in person or through digital platforms, services, or technology. We believe our leadership has positively impacted the quality of digital health solutions in the provision of physical therapy, as evidenced in this report, and with high participation of the associated companies in our digital transparency pledge, our practice guidelines, and growing support of the research and evidence base. APTA's growing concern is differentiation of in-person versus virtual physical therapy and healthcare coverage, as digital healthcare solutions are being associated with expedited access, lower costs to the consumers, and fewer administrative burdens, as well as at times positioned as a wellness-based over inpatient care, which is positioned as a medical benefit. Equity and planned coverage of physical therapy, regardless of if its mechanism of delivery is virtual or in person, is essential to capitalizing the value the profession provides to musculoskeletal care. We applaud this recommendation by PHTI and will advocate for its implementation with health plans and employer purchasers of healthcare services. PHTI's report also highlights that virtual musculoskeletal solutions have the potential to expand access, lower costs, and improve patient outcomes. We're especially delighted by the impact that it can have on health equity. APTA recognizes and supports the potential for technology to augment physical therapist practice, but that we continue to see that the role of the physical therapist is essential. Virtual care can provide new mechanisms to connect patients and help ensure PTs are providers of choice on musculoskeletal care. PT remains under-leveraged, undervalued, and overregulated in the healthcare system, and we believe virtual healthcare solutions can help eliminate some of these issues. So in closing, APTA applauds the initial work of PHTI. We encourage payers and purchasers to invest in physical therapists in all mechanisms of care delivery to lower costs and achieve better outcomes. So thank you to Carolyn Pearson and the PHTI team for their landmark work and their continued impact on healthcare in the United States. Thank you.
Thanks so much, Justin. I really appreciate it and appreciate you being here with us today. So now we're going to talk about the economic findings. And as I've said all along, it is important that we start with clinical and we understand the clinical benefits, but having seen really promising clinical results, we want to understand whether these technologies can also improve efficiency in healthcare. And we were very pleased to see in our modeling that there are strong signs that that's possible. First and foremost, I want to highlight that we always build our own budget impact models separate and apart from any of the health economics data that the companies or the solutions are able to produce, really to determine if we can provide an independent view to those that are reading the report about the potential for economic savings across these solutions. In this case, we decided to build our model really focused on low back pain and patients experiencing low back pain. The reason for that is where the evidence base is strongest, and we wanted to ensure that we had robust inputs to our model. However, there is good evidence to suggest that the findings from low back pain are translatable to other conditions. And we saw good evidence from several of the companies that similar or greater savings are possible in other musculoskeletal conditions and other body parts of focus. So when we look first at the physical therapist guided solutions, which are the results you see here, we really have two core ways that these solutions have the potential to deliver savings. First is, can they lower the cost of physical therapy given the technology enablement that you see in these solutions that allow them to treat more patients with fewer physical therapists, and that cost reduction does play through. And then the second benefit is really reduced healthcare spending from avoided care like surgery and imaging, as I mentioned earlier. And we saw both of those results come together in our modeling to result in a model that suggests that on a per year basis, users of virtual musculoskeletal solutions in the PT guided category could save between about $730 and $1,300 per user per year. Now, I will mention that these estimates are net of product costs, and of course it varies based on what the employer, the health plan is paying for these solutions. And these numbers are generally a lot lower than the numbers that you see from many of the companies. And I think there are many reasons why numbers vary. These are presumably conservative estimates, but I think they give you a reliable sense that there is good evidence that these solutions can save money across both of the variables that I mentioned at the top of the slide. These are really hard. This is a hard area to produce reliable estimates because there is so much selection bias within the evidence base. We know that people who engage with solutions and engage in their physical therapy actively are going to be the motivated users, and that those people tend to heal better. That's a reality that we work within, but I think these estimates suggest that even accepting that, these solutions have real potential to deliver savings to insurers and to employers. On the next slide, you will see the results for the RTM augmented solutions. And these results are a bit different, again, because of the design of these categories that I mentioned earlier. The RTM augmented solutions are not replacing in-person PT. They are supplementing with in-person care, and they're being paid for on top of reimbursing for any in-person PT visits. As such, they do add cost to the insurer, to the employer, with that additional billing. However, I think it's important to flag the RTM codes are very new, and the data is limited in terms of both what the patterns of billing are and what the clinical results are. If you think back to the clinical findings, we do see that users of these RTM augmented solutions actually had better outcomes on pain and function measures compared to people who are just doing in-person PT alone. What we don't yet know is whether those improvements on pain and function are sufficient to translate into lower spending over time that might eventually be able to offset the cost of the added RTM solutions. So this is a really emerging area where we intend to continue to watch the data and look for more evidence. Next slide. So taken together, this shows you the category and level ratings across both clinical effectiveness and economic impact that produce PHTI's summary ratings on the right-hand side. And generally speaking, what you'll see is that the physical therapist guided solutions performed very well. And we feel warrant broader adoption, both by purchasers, whether that be health plans or employers, as well as by users who can feel confident that these solutions offer value comparable to in-person PT. However, as purchasers approach this market, they also should think about what is the purchasing decision and sort of who is the patient population that they are targeting. App-based exercise therapies, if they can be deployed at low prices, have the ability to extend benefits to folks who may not otherwise pursue in-person PT and can still deliver value both clinically and perhaps economically at the right price. RTM augmented solutions with that superior clinical value really need a bit more targeting to understand how they can benefit higher acuity patients with higher acuity MSK conditions, and are probably best thought of in an increasing shift towards value-based care, which we will talk about a bit more. Next slide. So I was so excited to see positive results here across both clinical and economic findings, and to really be able to endorse the role of these technologies in delivering value to both patients and to payers. But there is work left to do. And so how do we actually continue to realize the full potential of these solutions? First of all, many of these solutions are currently being sold through the wellness benefit to employers, and they are not integrated into the medical benefit. As a result, they are generally not listed in a provider directory. So if a patient is told to go to PT, they don't see virtual solutions in front of them. Many patients may not even know they're available to them. It is also then harder to integrate back into the claims environment and the care environment, to allow providers to refer to these solutions, to get information back from them, and for payers to capture the actuarial benefit that may be accruing from these solutions. And so I think with the strong evidence base that we see here, it is time for employers and health plans to begin to integrate virtual MSK solutions into the medical benefit so that we can really create parity between in-person and virtual care and achieve the benefits that they each can deliver. Second, we see this evidence really shows us the potential for continuing down the existing journey to encourage more PT first care. We know that if you start your care journey for MSK with a physical therapist, your outcomes are better and your spending is lower. Virtual solutions offer one more opportunity to drive towards that PT first care for patients with a variety of MSK disorders. Third, we would like to see more focus on value-based payments. With the strong clinical evidence and economic benefits that you see in this report, the potential is there to be contracting with performance guarantees. And we increasingly have seen several of the companies that are described in this report offering financial performance guarantees, and purchasers saying that that's very important to them as they move forward. Fourth, we are recommending that virtual solutions can be partnering more tightly with payers and providers to improve patient triage. What this means is, how can we work with providers to ensure that when they are recommending PT to their patients, that they are offering them virtual solutions in the hopes that more people adopt PT, whether it be in person or virtual, whichever is going to be the most likely to get them into care. And finally, we are focused on continuing to build the evidence base. While we see strong evidence here, there are many gaps, which we can talk more about. But it's very important that we continue to build the evidence base about how these solutions work for people of different levels of MSK acuity. Can we get affordable exercise-based therapies in place for large swaths of the population who are relatively low acuity conditions? And how do we more effectively integrate hybrid care and value-based care into serving people with complex conditions and high risk for surgery? Many of the companies in this report have started to focus on this, but the evidence remains pretty thin about their ability to contribute to greater surgical avoidance. And this is really where the benefit to both patients and payers is going to come long term. And we urge more engagement on that evidence generation in the future. So with that, I'll give you a sense of what's next, and then we'll jump into Q&A. With our first 2 reports released, we have 2 more coming up for the rest of 2024. Next up will be digital hypertension management with solutions that may remind you more of the diabetes solutions, but a very different clinical area than what we saw there. And before the end of the year, we'll turn to virtual care for depression and anxiety, thinking about technology solutions seeking to treat mental health care. And with that, I'm going to invite Jared back to join me, and I would love to dive into our Q&A.
Great. Thanks, Caroline. Okay, we have a lot of questions coming in. So first question, you talked through the 3 categories of products outlined in the report. How did PHTI decide which products fell into which categories?
So we do a lot of work to research the company designs and how they are staffed and executed. We're really trying to look at sort of comparable care delivery models and sales models. And so in this case, the first category, that exercise-based therapy, have lower involvement from the physical therapists. There are definitely licensed physical therapists working at those companies, but they're not quite as integrated into every step of the care plan. Category 2, as I mentioned, really does have those physical therapists participating throughout. Many of them are augmented with coaches, but they do at sort of each of the critical care points, the physical therapists are involved. And then category 3, as we mentioned, is really different in terms of that's the highest level of PT involvement. And that's really, in addition to your in-person physical therapist that's working with you on a day-to-day basis. So that's really how we separated them out, and based on all the information that we got, both from research and from the companies.
And sort of along those lines, in terms of teasing out products and companies, some companies have multiple products or solutions within the MSK space. How does PHTI choose which ones to assess?
Yeah, that's a great question. And actually, it was really exciting to see how much differentiation is starting to come to this market. You heard me say a little bit of that, which is somebody with a very complex MSK condition may need a lot more sort of hands-on engagement versus someone who strained themselves at work or at the gym and really could benefit, but at a lower touch. And so we are starting to see some of these companies sort of split folks into tracks. Generally speaking, we have tried to focus on each company's most widely marketed solution for the real common causes of MSK pain and dysfunction, and with a focus on virtual PT. So to the extent that there were sort of lower or higher intensity solutions offered, we're looking at the higher intensity ones that might be able to be substituted for in-person PT where relevant.
Okay. Next question. So shifting a bit to the type of clinician engagement that PHTI had in developing this report. MSK care is by its nature multidisciplinary. So what kind of clinicians did you involve in the process of developing this analysis?
So our clinical advisors, which are listed at the front of the report, included a number of orthopedic surgeons and orthopedic specialists, as well as a physical therapist who works mostly in the in-person setting. And their views were really important and quite different, as you would imagine. So our physical therapist was incredibly helpful in helping us understand, what aspects of physical therapy require in-person care. How are physical therapists thinking about sort of that, sort of diagnosis point? So of course, one of the things that's interesting is it's not always obvious where someone's pain is coming from, right? You can have referred pain, you can have tightness in other areas that's causing issues. And so, she really helped us understand the role of physical therapists in getting folks onto the right exercise regimen that's actually going to target the right condition. And then our orthopedists, of course, were important both in thinking about clinical care around pain and function and how to get folks healed, but also a lot about sort of how that care journey works and in terms of referring to physical therapy, why patients do and don't go. And so we really benefited from each of their expertise on this report.
Okay, there's a couple of questions coming in on the economic analysis. So the first question is the price information in the report that was used. There's a pretty big range. How did you choose those numbers, and which numbers should purchasers go by who are evaluating these solutions?
So we had the benefit, I mean, first of all, we were so excited to have really robust engagement from many, many of the companies in this report. It helps a lot in terms of really understanding the solutions and the approach. And so that was wonderful. And as a result, we had real pricing data, both from published pricing in various studies and other sort of externally facing materials, as well as proprietary pricing information from a bunch of the companies. And that includes companies telling us both sort of what their list price is and what kinds of discounts are generally being negotiated. So we feel pretty confident that the pricing range represents the real spectrum of prices available from the solutions in the market. But any given purchaser is going to negotiate its own unique price with each solution vendor. And obviously, we were trying to sort of give folks a sense of how those savings vary across prices, because they're going to need to be adjusting and thinking about what the price is going to mean for their outcomes. So that's the case. Unfortunately, we didn't have good pricing information for the exercise-based therapies, which is where, because the price was so important on this budget model, we wanted to not overreach on that one. And so that's where you see the lack of information on that piece.
Okay, that makes sense. Another question on some of the choices made in the economic modeling. So you mentioned this a little bit, but wondering if you could elaborate. Why did the report focus on lower back pain as an indicator of whether the tools deliver clinical value? Just a little bit more on that decision.
Yeah. So the challenge is actually, the care journey for an MSK patient does vary based on the body part that's affected. So, for instance, we've all heard about back surgeries, which are generally not as effective as you might think. But the proportion of patients that get back surgery versus, knee injuries, you see a lot of injections on knees. Like the patterns of utilization do vary a bit by MSK condition. So trying to build a generalized model across all MSK conditions loses a bit of the granularity about really where the savings come from. And so we felt like it was worth trying to hone in and create something that felt really credible on just low back pain. As I mentioned, actually, Omada and SWORD both have clinical or economic evidence that parses by condition type. And, that gives us confidence. That gives us confidence that those benefits are going to accrue in other areas, even if they may be a little different.
Okay. Okay, a methodology question. How does the methodology of this report, which focused on MSK, compare to the first report that was focused on diabetes? I
love this question. Same methodology, no changes. I think there's been a little bit of discussion about, sort of, did we change our methods? Did we get feedback and do something different? The answer is no. We executed the same process. Every report and every condition area is a little different, right? You do have to sort of think carefully about which outcomes matter and how to sort of order them in your evaluation. But I think this, as I said, this report had 15 outcomes measures that we reviewed in the literature review. I think diabetes had 16. So really similar, but then, you got to think about sort of how to interpret the data and how to work through it. And so, we tried to do that as sort of consistently and fairly as possible.
Got it. And on the economic model, sort of similar structure as well.
Yeah, the economic model is a little more bespoke. Obviously, you have to build it based on sort of where the evidence is strong, but it was similar, right? We sort of took we sort of looked at what is the primary indicator of savings. So on diabetes, it was HbA1c. On MSK, it was really sort of folks that are getting into physical therapy and how early and often they're getting into physical therapy. And each of those was sort of the driver of like, how do we determine which treatment path, which healing path folks are on. And then, you've got sort of models that exist that give you good predictions of how those different care journeys are likely to affect spending.
Okay. Okay, another question on company engagement. You spoke a bit to the importance of kind of engaging with companies throughout the process, but can you just elaborate, how does that company engagement sort of shape the assessment process, and how did you engage with the companies that were evaluated in this report throughout the process?
So we reach out to each of the companies that's, once we pick a report topic and scope it and determine which companies are going to be included, we reach out to them, explain a little bit about who we are, and give them the opportunity to submit additional information to us. But we also have a lot of calls with those companies to really sort of understand the product design. We had the benefit of getting some demos and really feeling out sort of how the different technology works. But then, the evidence that's submitted goes through the same rigorous review process that we use for published evidence. So each of those pieces of evidence is reviewed for risk of bias. We are trying to make determinations about sort of its credibility and validity as we're sort of integrating it into the broader body of evidence and then thinking about it holistically.
Okay, another question about the kind of difference between medical benefit and wellness benefit and how some of these products fit in. So can you share more about your recommendation towards the end of your presentation on aligning these technologies with the medical benefit as opposed to the wellness benefit?
Yeah, let me tell you a little bit about what happened to me. I think that's a good example of sort of benefit design gone awry. So I had an accident. I broke my leg quite seriously, had surgery, so wouldn't have been included in the report, but needed a lot of PT in order to be able to walk again. And I went to my orthopedist. They said, you need to go to PT. It never occurred to me that I had a virtual solution that was covered and available to me. I had no idea. I, being a good insurance person, went on, checked my network, found my physical therapist a few blocks away, and started doing 3 times a week PT during business hours. When it's not always the easiest given my lifestyle. And then some number of months later, I think it was about 5 months later, I got a letter in the mail saying this virtual solution's available. And what happens is these companies, because they're in the wellness benefit, are sort of doing regular claim scrapes. And so if there's a PT visit or orthopedics visit, it's triggering it. And then they're really doing mass mailing. Many of the companies told us that they recruit users by putting posters up in break rooms, which is great. But we can do better than that in the era of technology. And so, the question for me is, if we've got, these are solutions that are delivering real clinical care with demonstrated clinical benefits and savings. And so, if they were part of the medical benefit, it would be a lot easier for patients to find them, potentially for providers to refer to them, and for them to sort of integrate into how do we actually help avoid other medical care, right? Which is really the value proposition that most of these companies are beginning to drive towards. And it's one that's not well achieved by sitting sort of outside in the wellness benefit. And then I guess lastly, and interestingly for those of us who are insurance nerds, there should begin to be actuarial benefits. Like if you're saving money from having one of these solutions, you'd love that to translate into lower premiums. And it's hard to achieve that if it's sitting in the wellness benefit as well. So I think lots of reasons to think about, it was good as an access play. It was good as we proved the data out. Now that we have the data, time to treat these as real care providers.
Right. Okay, a few more questions. We're getting towards the end of our time. We have time for a couple more. There's a lot of questions coming through. So next question. what reactions are you hearing from payers and purchasers following the publication of these two reports? Are there any cross-cutting themes? Are there any lessons that digital health companies can glean from these two assessments so far?
Yeah, I mean, we have just had tremendous enthusiasm and appreciation and huge levels of engagement from purchasers. And that's really, for these two reports, that's predominantly health plans and employers more than providers at this juncture. And they have really said, we've been struggling with this. This is, we can see the quality of the analysis, and we really want to think about how to immediately integrate that into guiding our decisions. We've been asked to join a lot of the these purchasers for meetings with their whole, they'll say, can you come talk to the whole team? Can you tell us about it? And I think what they are really excited about is how this is pushing towards more evidence and sort of higher standards in digital health purchasing. And, I think with the COVID pandemic, folks knew that we needed to adopt technology, knew we needed to improve access. People really understand the theoretical value proposition of many of these solutions. But the purchasers want to say, okay, as years have gone by and we're integrating these, how do we do it better? How do we measure? How do we make sure that we're getting the value for our members or our employees that we think that they deserve and that we're paying for? And so, they just continue to be super engaged in ways that I think are very productive and heading towards a more evidence driven future.
And any lessons learned for digital health companies?
Well, I think, the message is, if the purchasers are relying on evidence increasingly, then generating evidence and demonstrating value through evidence, becomes the currency. And that's great. That's a great outcome. But it does, of course, mean that becomes a high priority as solutions are developing and seeking to show value to the market.
Okay, so we'll go to the last two questions. So when you gave your sort of personal example, you sort of highlighted the challenge of accessing some of these benefits if they're not part of a medical benefit. For the companies out there, what can the companies do to increase uptake of virtual MSK tools?
Well, I think there's sort of two different groups, right? I gave you the example of someone who was going to go to PT, but probably at least at a certain point in my journey could have benefited from a virtual solution. I travel for work. I have a busy life. Convenience was important to me. And so, for that, I do think integrating with medical benefits and working really closely with providers, like increasingly working with providers, right, to raise awareness is the key. The second group is really folks that wouldn't otherwise go to PT. And a lot of people get referred to PT and say, I'm not going to do that. And, how do we convince those folks that this is going to be effective and convenient? And, a lot of the sort of general marketing solutions are good for that. But I think leading with evidence, I would not have wanted to choose a virtual solution if I didn't think it was going to be as valuable. My healing was the most important thing to me. And so I think the evidence that these things work is really valuable to patients who just want to get better and just want to address their pain.
Okay. Last question. Thanks everyone so much for joining and for submitting your questions. So was there a solution that rose to the top?
Well, it is not our job to pick winners, right? We are trying to sort of show evidence categories and give purchasers confidence. Every purchaser is going to need to make their own decision based on the variety of variables that are important to them. But if you ask me, I care about evidence, and I care about clinical evidence, and I care about performance guarantees. And the company in the report that had the best evidence and a performance guarantee was Sword. So if it was me, that's what I would pick, but everybody's going to have to make their own choice.
All right. Thank you, Caroline, and thank you everyone for joining today.
Thanks so much. Appreciate y'all.